In this edition of BRG's Nurse Executive Podcast, I speak with Kim Vance, a registered nurse by background and associate director in BRG's patient care optimization team. We discuss nurse manager span of control. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Chmielewski.
Kim, thank you so much for joining me today.
Thanks, Nick.
Prior to going into consulting, can you share with the audience a little bit about your nursing leadership background?
I've been a nurse since the early 80s, and I have had a wide range of experience as a clinical nurse in emergency rooms, critical care, and a little bit in outpatient. I've been a nurse leader for over 25 years. My last position was at an academic center as an assistant chief nursing officer. I've been consulting for 5 years.
And so now the work that you're doing is more related to nursing staffing and inpatient care optimization, but you're also doing some work around span of control. Is that correct?
That's correct. During this last couple of years, the healthcare outlook has dramatically changed in nursing, and the nurse manager role has tremendously been impacted by these changes. So I think it's very important for us to really take a deeper look at the span of control of a nurse manager.
What type of changes have you seen in the nurse manager role since COVID?
What I'm seeing is organizations continue to add expectations and responsibilities to the nurse manager's role. At the same time with this, the nursing workforce landscape is changing. Today's nursing workforce is younger and less experienced, needing more supervision and mentoring. Staff nurses are requesting more flexible work week and work hours, leading to an increase in part-time and hourly nursing staff, giving nurse managers an increase of staff to oversee. So today, it's more important than ever for organizations to take an inclusive approach in identifying the optimal span of control for the nurse manager, and not just to look at the number of FTEs or the number of staff.
Yeah, so when we're talking about span of control and the number that a particular nurse manager may oversee, what is the right approach with that? Do you want to look at it from number of people, or are we truly talking about a full-time equivalent?
There's several factors you have to look at. And the number of people, the FTEs, the number of people is important, as well as professional versus non-professional staff. But there's a lot of other types of factors that we need to look at as well.
All right, let's dig into it. Tell me all about all the factors we need to look at.
Here's a few that you need to look at. And one of those is the complexity of the work. What are the hours of operation? Does that unit serve, or does that manager have multiple service lines that emit to her units? Is there a high patient turnover? Are there a number of safety and adverse incidents happening on that unit? You need to look at all those pieces. And for specialty areas like ED, OB, ICUs with high intensity, they would warrant a lower span of control than a unit that had more routine and predictable workload. You would also want to see, is this a unit that has a high risk for litigation? That would be another area that would need a lower span of control. And you want to identify what's going on in that unit. Are there a number of safety and adverse incidents going on? You would want to look at the workforce, the number of staff directly reporting to the clinical manager, what's the experience level of the staff. If you have a high level of novice nurses, new graduate nurses, what's the stability of your unit? Is there a high turnover? What's the absenteeism?
Okay, so you've
And
given a long list there, Kim. That sounds like a very qualitative approach in evaluating what the right number of people a nurse manager would oversee. Are there any quantitative components to that as well? Or how do we start breaking that down and really understanding that nature?
the whole piece here is one size does not fit every organization. You have to look at that organization, their structure, their environment, and you need to take then and look at these different pieces. What support is there for the nurse manager? What kind of administrative support? Do they have in their structure? Do they have assistant nurse managers under them that can help with the normal expectations they have for their daily operations? Do they have assistance with the budget? Do they have a staffing office to help them with the scheduling, call offs, and all that? We want to know where the nurse leader or nurse manager is spending their time and how can they be effective if they have to spend all this time doing all these tasks. So what resources are available for them? If you have a high turnover rate and you have less experienced nurses, you're going to need a lower span of control. If you have a stable staff and you have a lot of experienced nurses, you can probably have a larger span of control. So really each one you have to look at what's going on that unit.
How often should a span of control be analyzed by a nurse executive? How often should we be looking at what's going on the unit, and do I have enough or not enough leadership based upon the nature of that unit?
One thing would be is looking at your outcomes on that unit. Also is when you have leaders retiring, managers retiring, that's a good time to look at, is there any changes I need to make? And why I'm saying that is that you may have an experienced manager who has been a great manager. Their span of control can be a lot bigger than someone who is a novice manager. So you got to look at that skill mix of the manager and what experience they have when you're doing this. So you could have a manager that's been over 2 or 3 units, and now you're putting a new nurse manager in there who's never been a nurse manager. You wouldn't be able to give them probably that type of span.
In your experience, Kim, and the numerous different organizations that you travel to across the country, what are some common pitfalls maybe that you've experienced when it comes to a span of control in the organizations that you're seeing and things that are not being considered? We just had a whole laundry list that we've talked about, but in general, are there some common areas that are not particularly looked at that should be considered?
I don't think we look at the whole scope of the expectations of a nurse manager. And I don't think we look at all the tasks that is on their plate. And especially, we know that the nurse manager is a linchpin for nurse retention. And they have to have that time to be able to spend with the staff. But today, we expect the nurse managers to do all the stuff that's on their plate, which is budget, scheduling, quality metric, patient safety, patient experience. But also managers are asked today in many organizations when the staffing is so short that they're out there staffing at the same point in time. So we have to look at what our expectations of the nurse manager are and what is realistic for a nurse manager, or what kind of administrative support does that nurse manager need. And when I talk about the support, as we talked about earlier, what's the hours of operation? You need to understand the hours of operation. Do we need some resources on the off shift? Nurse managers try to come in early, stay late to see their staff that's coming on the off shift. But is that really the best time to be seeing that staff? So should we have some support for that nurse manager on off shifts?
Couldn't someone argue that that's the role of the nursing supervisor, to be available to nights on the off shifts? And I'm not necessarily agreeing with that, but prove to me that I'm wrong, that it's a nursing supervisor, house supervisor, if you will, compared to having additional unit specific leadership that's there on the off shifts and weekends.
As we talked about earlier today, we have more new grads. As nurses are leaving the workforce, we are replacing them with new grads. And you're right, you have a house supervisor overseeing the hospital, that's not building that relationship or mentoring or helping those new nurses to feel more comfortable and to help them build their critical thinking skills. And we all know with retention, it's about building relationships. And the younger generation is wanting to have answers to things real time. We are a 24-hour operational organization, but most of our leadership and most of our work has been on a 9 to 5. How do we switch that and make sure that we have the right resources and support for the night shift? Look at the night shift and what their needs are.
Let's imagine for a moment, Kim, that we've got a ICU that's taking care of both medical and cardiac patients in a critical care environment. And we'll say that it's a 30-bed ICU, so a little bit on the larger size, right? And, we're looking at this and saying, all right, how do we support this unit outside of the nursing staff and the unlicensed staff that's there supporting? And from a leadership structure, we've got a limited number of FTEs or a limited number of funds. What model would work best there in terms of, do you go with a one manager over the unit and maybe an assistant manager for both day shift and night shift? Or is there an opportunity for an educator that's dedicated to the unit, but we'll also put 2 educators instead of, one manager and 2 educators instead of 1 manager and 2 assistant managers, or one of each? What are your thoughts on where that balance lies in determining how that can work best for the ultimate leader of the unit and span of control?
We like to look at the number of people. Pre-COVID, it was always said around about 40 to 45. And there's literature out there that shows for outcomes, patient outcomes, satisfaction scores, staff satisfaction, around 40 to 45 staff members, not FTEs, staff members to a leader was still effective. But what I am saying, it's not just the number of staff, it's all these other factors or expectations of the manager that needs to be taken into consideration. You have to look at that whole picture. You also have to look at the environment, what you were saying, a 30-bed unit ICU. In that 30-bed ICU, do we have someone who's doing the quality indicators? Do we have someone who's assisting, like you said, nurse educators? Are they in the unit? Are they hospital-wide? What kind of support, what kind of administrative support, if it's not a nurse manager, but what kind of support does a manager have to take some of those tasks or expectations that they can delegate elsewhere to allow them to see that bigger picture?
Kim, I understand that you are using an evidence-based nursing leadership span of control matrix, and it allows you to look at 16 different factors to determine whether the span of control on that unit is too much, meaning they have too much responsibility, it's just right, or there's actually maybe some opportunity for improvement in terms of reducing the number of leaders that are present. Is that a correct understanding?
That is correct. But I would also say that when looking at this form, it would really be making sure we're really capturing the expectations, really looking at the roles and responsibilities up front and looking at if they have assistants or they have nurse leaders, coordinators, whatever they have, and looking at their roles in trying to get a matrix there of who's responsible for what, who's the primary responsible for X, Y, and Z, and who's secondary. Because a lot of times everybody thinks that's their primary responsibility. So then we're not utilizing our leadership resources efficiently. So that's really step one. I like to sit down with the leader and do this together. So you have them to talk about how much time, where they spend their time. Then after you get these results, you can look at it, and you're right. It will give you, if you have just the right amount, you have more capacity to take on more responsibility, or you're over. But you can also look at this and say, hey, they're spending a lot of time here with scheduling and staffing. Is there technology that can help support them on that? Is there resources that doesn't need to be a nurse manager doing? Can we put some more things in the staffing office to free that nurse manager up to do more things with the staff and really getting that cohesive group taking care of the patients and getting the right outcomes?
Just looking at this spreadsheet, there's some really good questions here that break it down into an easy way to rate the matrix. What is the percentage of novice nurses on the unit? And you're breaking it down in terms of less than 5%, 6 to 15%, or greater than 15%. How many staff directly report to the manager? Is it less than 31? Is it 31 to 70, or 71 to 100, or potentially even greater than 100? What is the breakdown, as you mentioned earlier, about what is the percentage of non-licensed staff on the unit of service? Is it less than 10% are non-licensed, 11 to 20, or greater than 20%? And even some more other interesting aspects I see on here about the patient flow on the unit. How predictable is it? And does it necessitate frequent reassignment of staff during a shift? Why is that important in identifying span of control?
Because it tells us about the workload on that unit and looking at efficiencies for that unit. If there's a lot of throughput, patients being admitted, patients being discharged, that's where there's a lot of workload, and trying to make sure that you have the right resources there.
So I get this result, and this result comes out and it says, hey, my span of control is below acceptable and I'm capable of growth. What should happen as a result of that? So the results of the assessment say it's below acceptable and I can grow. Where do we go from there?
That's where your executive nursing leader, your directors and stuff need to sit down and look at what do we have, because having someone who's under, you may have someone else who's over. So do we have to do a realignment? Do we need to look at things differently? Do I need a manager on this unit, or can I buddy it up with another unit? And even doing that, you need to look at the geographic location, because you can't have a manager over one area and then the geographic location of the other unit is far away. That's just inefficiency for managers to be able to manage their units. Take these results and look at what's working well, and where do we have that opportunity to make some adjustments to our nursing manager span of control? Are there tasks and things on here that we can give to someone else to do?
When we find ourselves in that situation where we're looking at, hey, we've got two units, and let's assume for a moment that we've done the due diligence and realize, you know what, I'm in a facility where I get off the elevator and I've got one unit to my right and I've got another unit to my left, and the unit to my right and to my left are relatively about the same size. And it looks like both of them have a span of control that is below acceptable limits and is capable of growth. And maybe we want to combine these under one manager. Would you reanalyze that then as one unit and using this same point system to determine, is this appropriate? Or maybe instead of two managers, we have a manager and an assistant, or a manager and two assistants? Walk me through what that process looks like.
That's looking then at that manager with that number of staff, with that responsibilities, which you took on two different ones and putting under one. But as you said, then you looking at assistant manager, would you have an assistant manager to support them on those units, or at least one of the units?
And on the flip side, when we come up with the span of control that says that it's excessive and that this nurse manager is clearly overburdened, what type of solutions should exist around that? It doesn't necessarily mean that you need another manager. There are other alternatives, from what I'm hearing you say, that could be explored. Am I correct in that understanding?
That's correct. What we're seeing is having that assistant manager not during the day hours. If it's not, is there technology to help support trying to staff their unit?
You mentioned technological solutions. What technology solutions could help with span of control challenges?
There's scheduling out there that can support a manager and do real-time texting. It will know if the staff member is who's on, so it doesn't text everyone. It'll text who's available out there. That would support them and give them time back instead of doing this all manually.
Great. You have given me a lot to think about when it comes to span of control that I'm not sure that I thought about until we had a conversation today. Are there any closing thoughts?
The main thing I would say is that, again, you have to look at that organization and you have to look at the resources they have available and what the expectation of that manager is to get the solution that's best for that organization.
Great, Kim. Thank you so much for your time today. I appreciate it. I'm sure you've given a lot for all of us to think about.
Thanks, Nick.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.